Okay. So on behalf of RuDASA, I'm going to welcome everybody to this webinar. And my name is Stephanie Homer. If you contacted RuDASA, I'm usually the person that's emailed back to you or been on the end of the phone. And I'm standing in for Madeleine, who would normally be running these webinars, but she is over in Europe, having a great time in London and in Rome. So I will be hopefully managing the Zoom. I'm a bit of a Zoom novice, but we'll see how it goes. So the topic today is looking at the medico-legal issues in orthopedics, which is a growing issue at the moment. And we asked Ben Gaunt and Hans Hendricks to share their experiences. Ben is a rural veteran, and if you're in Eastern Cape, then you probably have heard of Ben. Spent many years at Zitaleli Hospital and has recently moved into the advanced area of medico-legal claims and the Eastern Cape. So he's been analysing the cases that Eastern Cape has been dealing with. He's bringing that knowledge. And Hans is a family physician, also long-term rural advocate, and worked at Zitaleli Hospital, but he's currently working in Uppington in the Northern Cape, which was quite a big move, I have to say, from Eastern Cape to Northern Cape. And he's also involved with the Aquanda Centre for Rural Health in the Department of Global Health. So, and Hans's passion has been orthopaedics. If you were in our onboarding webinars, then you might have attended his Making a Break with Orthopaedics sessions. So I'm going to hand over to them. We are live streaming on YouTube. There are CPD points attached to this. To get the CPD points, you have to complete the poll at the end of the session. So over to Hans and Ben.
Thanks very much, Steph. And hello, everyone. I guess we'll have to stick around to the end of the session then, Hans, and complete that poll. We're doing something very different. And we're happy to hear feedback on whether it works or not. But we figured we've both been privileged to be part of the onboarding sessions at the beginning of the year. And Hans spoke on orthopedics, and I spoke a little bit about medico-legal things. So tonight, instead of boring you with a bunch of slides or letting you kind of have the slides and switch off to what we say, this is Ben and Hans, or Hans and Ben in conversation about this topic, which is increasingly relevant. But I think you'll find that in many ways, it could have been titled something like Doing the Basics Better or things like that. But we didn't want to just make it that, because what we're hoping to do is in some ways reassure you about the medico-legal ogre that it feels kind of sits right behind us waiting to pounce at any given moment. We want to give you some tips and thoughts about how to go about seeing your next orthopedic patient in OPD, because that's the reality. We work in busy settings, and we can't get it perfect every time, far from it. And really we want to speak to just the reality of what it means to practice good quality, safe medicine in orthopedics or any discipline for that matter at a district hospital level, and in doing so, hopefully avoid the medico-legal pitfalls. So that's kind of by way of introduction. We're really going to try and be in conversation with each other. We're going to interrupt each other and go down rabbit warrens perhaps and try and see where that takes us. Neither of us are orthopedic specialists, and I see there's at least one on the call. So we don't claim to have the last word on it, and we're certainly not experts, but in some ways, the idea of these talks is really to be as coalface focused as possible and give you that kind of view. And yeah, hopefully a view that has been honed by years of doing it. Hans, I don't know if you wanted to say anything else by way of introduction.
Yes, thank you, Ben. I think we did this once before when I was still working with you at Medico-legal. We had a discussion on how to do a cesarean section well and safely. And the discussion started and it actually was lovely, going layer for layer inside and the whole discussion. I think in the end everybody had an opinion in the whole team. So it was, I think it's a nice way of doing it. Just as I'm working in a level 2 hospital, district regional hospital currently. So we have an orthopedic unit where I work now, and I do calls for them. And I run the casualty. So kind of like in that setting, I for the first time in 15 years, I actually look back down in a nice way to the district hospitals. And I kind of also see, the mistakes we made referring upwards and now the mistakes we make, accepting from referral hospitals, from district hospitals. So when I give advice, it's kind of like from that perception. Thanks, Ben.
No, I think that's a helpful reminder right at the beginning, because the reality is that, while we often see ourselves in our little silos, be it a district hospital, regional hospital, the patient is coming to us because they want care for their problem. In this case, probably a broken bone or dislocated joint, something similar. And they don't really care about the politics that exists or the different levels of experience or expertise or just the availability of equipment, et cetera, et cetera. They want care. And in fact, from a medical legal point of view, pointing out as well that, when we get sued as departments of health, it's the MEC that gets sued, because the whole idea of the lawyers isn't to try and pin it on the actual thing that went wrong, but to say, hey, you, the health system, you let this patient down. And I think so your kind of perspective from regional hospital now, that's going to be super helpful, because we are one system of doctors caring for patients, and we don't always carry that in our heads or hearts sometimes, but I think that is super important as we come to orthopedics as well. So we actually thought we would start off just with a context setting set of kind of numbers and perspectives, and then use those as a springboard to actually jump into, okay, well, what does that mean for the management of fractures? And we'll have to keep an eye on time as we go. So as Steph said, I've been working as a clinical medical legal advisor in the Eastern Cape, and that means that I get sent the files of the cases that are about to come to court pretty much, and get asked to provide a clinical opinion, taking into account the clinical notes, hopefully, if they're available, the x-rays, if we're talking about an orthopedic case, the expert reports that have been done. Usually the plaintiff gets one expert to say we were terrible, and we find an expert who said we weren't that bad. And then we, I look at those and try and see, from a clinical point of view, is there a way forward clearly in any one direction or the other? And sometimes we have to concede them, and then that goes up the food chain. So I don't get to make any decisions, which is actually delightful. But so in a year, or just short of a year, I've analyzed 120 different cases in depth, and 20 of those are orthopedic. So that's the first message out there. The two in the Eastern Cape anyway, and I think it's reasonably common across the country that this is kind of the split. We're looking at about 80+% of the cases that are medico-legal against departments of health being obstetric, the vast majority of those being cerebral palsy cases. There's obviously several other obstetric-related things that get taken to court as well. But the second biggest discipline by far is orthopedics. So, in my year, I've seen 80-something cerebral palsy cases and 20 orthopedic cases, and then the other disciplines are really small change. So on one hand, the message is, this is not every broken bone that's going to land us in court, not even remotely. But on the other hand, the message is also that orthopedics is increasingly a challenge for us, and we get taken to court for them. Hans chip in if I just talk to
Can I say something, Ben? What the thing with orthopedics is government service we monitor, and the health parameters we look at are maternal deaths, neonatal mortality rates, those life and death things, and orthopedics just falls under the radar because mostly people don't die from what happens, but the disability is lifelong quite often if we make a big mistake. So the result is huge, and I think the service have been at times, like I'm just thinking back when I worked at ECDOH and where we referred, like ankle fractures was the end for me. Ankle fractures was what gave me PTSD when I think back, because they never got operated. I felt I completed more disability grants for young people that couldn't walk due to pain than they operated the Weber B's and C's that needed to be operated. So in obstetrics, we see the baby that died and the emotional content thereof, and the mum that died, heaven forbid, and all those things. In orthopedics, it kind of fall through, and we tend to miss we can't kind of yet see the long-term disability that's caused by the mistake being made.
Yeah, no, I think you're absolutely right, and I think that is why it's such an important topic. We often talk about life and limb. I mean, orthopedics is very much limb. And it's super important to people because it's often related to their livelihoods as much as just disability. So out of those 20 cases, it is interesting, kind of the breakdown. The lower limb has been responsible for 7 cases and the upper limb for 9. But the value of claims for the lower limb is substantially higher. The average claim for an upper limb issue is 5 million and the lower limb is 8 million. And I think that reflects obviously the impact on working life. But the 2 other things to kind of be aware of are Volkmann's contracture and amputation. So between those 2 kind of subheadings, we've had 3 cases, and that's obviously also fracture related, compartment syndrome, or plaster of Paris related. So that's the kind of the type of claims that we're seeing. And then just kind of from a numbers, 2 other points from a numbers point of view before we dive in, and maybe ankles are the best place to start when we dive in. The mix, interestingly, I think this is also an important message for people who feel like we are under assault, by the legal fraternity. About 45% of the cases I see are defendable, in my view. And unfortunately, I haven't been doing this long enough to know the outcome, because the courts, I mean, the wheels of justice, they turn imperceptibly slowly. I literally was assessing a case, a woman whose child was stillborn in 2005, and she brought suit in 2008. It's 15 years later and it's not settled. So this is the reality of the legal system. But as I say, about nearly half of the cases are defendable, and that should be encouraging as well, because it's not that we are completely defenseless. There's stuff that we can do, even when we are overwhelmed to some extent. So I think that's good to keep in the back of our mind. Now, I just wanted to go through what are some of the avoidable factors. I've been trying to add an analysis of that into the data that I collect. And the 2 biggest ones are, not surprisingly, number 1, no X-ray post-pop or MUA. So that's something we're going to, I think, touch on a lot as we talk about how to avoid this in the outpatient setting. And the second one is delayed or no antibiotics, and that's obviously in the case of open fracture. And those are the ones that have cropped up repeatedly. The other kinds of things, just so that people are aware of them, a fracture that was judged healed prematurely. That was a kind of a unfortunately wrong clinical judgment. And I think that's, again, that kind of thing happens. Obviously, we want to avoid it, but sometimes we get it wrong. And I don't think we need to be too focused on those times when we just get it wrong. It wasn't that we knew what to do and we didn't do it. There was a wrong judgment call. It was a very optimistic removal of an X-fix on a tibia that had only been about 6 weeks in the X-fix, I think. So it unsurprisingly didn't stay straight. Fracture missed That's an issue, especially around the elbow. Fracture reduction not done. I think we're going to touch on that when we talk about who's responsible for it or for managing the patient. A very bizarre case where the elbow was dislocated. They made an attempt to relocate the elbow and then failed and sent the patient home in a plaster without referring. So that's an obviously avoidable one in my view. And then a vascular injury at a dislocation that was missed. So, you know, I think as we go through it and just touch on fractures and dislocations, the reality is that so many of these things are about just doing the basics. Yeah, Hans, I don't know if you want to pick up from there.
Yes, Ben, I think, you know, before we talk, I've got a nice list and discussion points on how to protect ourselves, but I think we need to talk about the reality in which we work. So yeah. In all the guidelines, if you think of like what you were taught how to manage, let's go back to ankle, Weber fractures, A, B, and C, how are you going to manage them? It's first world data that tells us these are need a RF and these you can do close reduction and these are in between, but it's very clear guidelines. But the reality in which we work is, I'm thinking where I currently work, we run out of hardware, we run out of theater sisters, we run out of diesel for the generators, and the theater list get cancelled. Our CT scanner, we've got one and it's been serviced for a year, but it hasn't run for a whole year because the legality thereof is not settled yet. So there's all these realities in which we work. And I had a discussion after you know, Ben and I spoke and it looked like we're going to have this talk. I spoke to our orthopedic surgeon. I asked him like, what does he think is important? And he said, just be very clear on what you do and how you do it. So be very clear with the patient, manage the patient expectations. From the admission, they must understand we've got a long waiting list. So last night I admitted a patient with a femur fracture and I said like this, I'm going to admit you, traction, Clexane, all those good things, but you're going to be probably not the next 2 weeks, probably in the third week, we're going to get you your operation. But then I try and put it into perspective, you're going to need this leg for the rest of your life. So it's probably worth the wait for 3 or 4 weeks. I'm sorry for the wait, but that's it. And like, so manage the expectations from the start. Then he said like, he's very adamant on writing in the notes exactly what's going on. If he doesn't have a CT scan for the tibia plateau fracture to plan before the surgery, he writes it very clearly. And if the patient is only operated 6 weeks, like I know Kimberly currently is running, that's the story, they're running at 6 weeks after the fracture, only they get to the patient. Now, I mean, it's terribly difficult operations by that time and getting through the callus. And he makes very clear notes on that. And obviously with the consent, you need to discuss that. And then also know your limitations. If it's a difficult case, if you sit at a district hospital, you're worried about the supracondylar fracture, it's a Gartland 3 that's twisted, and you're worried about vascular compromise, refer and discuss and make a clear note. So record keeping is to a large degree how we protect ourselves. But the reality is, in the end, we can only do and work with what we have available. I think that is a big thing that causes burnout in this country, because for doctors, because we feel we should be able to do what the Americans are doing in their first world setting. We need to do the best with what we have available. And then for the rest, we make notes and we make plans.
Hans, I think that's so true. I mean, we often use that phrase at Situlele, didn't we? You know, do the best that you can with what you have. And I think that, you know, another phrase or another kind of perspective I share with people, and some people have found it helpful, so it might be worth repeating, is that I think to really make a difference in the public sector in South Africa, perhaps in many similar settings, you have to strike a very fine balance between being dissatisfied with the status quo. In other words, it's not great that we put a femur fracture in the bed for 6 weeks. You know, that's not cool. It shouldn't be like that. Not in our country, where our GDP is, you know, what it is. And et cetera, et cetera. So we must say this is not cool and we've got to keep working to make it better. But you also have to find somehow within yourself a level of acceptance of the status quo that is sufficient to allow you to continue functioning in that space, because otherwise you do just burn out and you do just get frustrated and you're going to leave either to the private sector or another country perhaps. But and that balance is hard to strike, but I've come to see it as quite important, because the reality is, as you say, we're not in the United States, we don't have unlimited resources. And frankly, sometimes I thought it wasn't unfair to describe us as practicing in orthopedics as it was in the 1800s, just that we have x-rays. So, and I think that context is super important. But just to come again from the medical legal angle, our courts understand that if we document it. So it was very interesting, and just to hop over to obstetrics, I've been involved with the guidelines there, and we're hoping that we're going to have what we thought would be a paragraph, kind of putting the guidelines in context, because there's this tension also between saying, okay, well, we want guidelines because we do want people to practice good quality medicine. We do expect people to do X, Y, and Z. And we do need to say, here's the standard. And we don't want it to just be aspirational, manage that fracture, try get the leg straight if you can. And if you can't, well, that's okay. They'll have a skew leg. Like, that's not what we but there's a difference between kind of what we understand as guidelines and how the courts see it. So we wanted to put this paragraph in, and it became a page actually after speaking to the lawyers, and we'll have to see what actually gets published in the end. But the bottom line was there are two aspects, and you've touched on the most important, I think, and that is the contemporaneous recording of the realities that have impacted care. So exactly as your orthopedic consultant said, you've got to indicate what has impacted the way that you treated this patient. If you couldn't take them to theater for a washout because there were 3 laparotomies back to back, well, that's just how it is, But then the question to ask yourself, of course, well, what's the next best? I'll come back to that. But the other thing is actually for management, so people in management, to try and document it as well, and to try and keep those notes, because we might only be litigating this year's cases in 2031. To say, management, I've made you aware of the fact that I don't have enough theater time, that we've run out of hardware again, that the CT scanner hasn't been working for a month, or for a year. Those are things that we're meant to document, and that's a management level function. But then when it comes to the way that stuff has impacted the individual case, we do need to make a quick note. And again, I think it doesn't have to be a book. We're not writing a 6th-year history where they get water from and how many brothers and sisters they have who've been to school. We write the relevant stuff, but it's relevant if you can't, there's no theater time for this patient until 3 weeks' time, and I've informed her. We can't do more than that. And in fact, the system as it exists currently can't do more than that. It's not a philosophical discussion about could it have done more than that if we'd done something differently. That's not the discussion. So I think that your point is super important, and recognizing that and accepting it to some extent is important. I don't know if you want to talk about the next best aspects, so what do you do? I mean, you said telling the patient, that's super important, documenting it.
Yes, I mean, we've been working really hard at Uppington to get our waiting times down, and we got it down from probably around 6 weeks to within 10 days. And now over this weekend, we got like 5, 6 femur fractures, and suddenly the list extends. But trying that, I think that probably the biggest change we made was developing good connection with our district hospital outreach and support system, where we did training in the district hospitals on the primary healthcare orthopedics, the stuff we did on rural onboarding orthopedics, so that the district hospitals do the best they possibly can. And then with that, the communication between us and them, they got better at doing the basics right. That's less referrals and less mistakes. But also there's a good relationship. So people phone and, by that way, it's been a big change within a year that we saw. So yeah, jumping ahead, management
use
things
Vula?
we can do.
Just talking about that relationship, do you use Vula for
Okay, yeah.
referrals?
So I've made some headings here, Ben. So how do we protect ourselves? Like I've got 5 big ones, and the fifth one actually, management points. I said use Vula rather than WhatsApp. Now I'm saying that we're still using WhatsApp, but we're going to transition soon to Vula. Vula is a way also of the orthopedic surgeon can monitor what's been said in the past. It keeps track of everything, all the advice anybody gives anybody. And if people say, but like we didn't know about that, you can just refer back. But there's some nice studies that's been published, done in Cape Town. I know the Kailicha had one on the effectiveness of giving advice over Vula and how district hospitals learn and do better, and then the referrals go down after a while, obviously. So Vula is a great resource. Building relationships with the hospital. I'm thinking two weekends back, I was on call. Springbok Hospital phoned me. Now that's 400 kilometers away. So if you call the ambulance, you need to have a good reason. But the kid the doctor told me about a supracondylar fracture, grade 3, terribly displaced. I mean, the distal humerus was sitting somewhere there behind the humerus somewhere, and very swollen. And I just said, send the patient. I mean, it's one of those that I don't even want them to attend the initial immobilization. Patient arrived with mean casualty with no pop, no backslap, no immobilization. And I was like immediately taken aback and angry. This poor kid on the bumpy road from Springbok to Uppington for 5 hours. And I didn't get angry. And we did the reduction, good start. We did the reduction, and then I just sent a WhatsApp with a post-reduction x-rays and said, like, thanks for sending the patient. Just in the future, remember, just splint the arm straight. Doesn't matter that you can't flex it, but just immobilize for pain. Even if it's straight, it's just a short term. And she was, she's so sorry, because she was just so worried about that arm. She didn't want to touch it, basically. And I mean, but the communication and the relationship wasn't broken. So I think that is relationships with the district hospitals is very important. The challenge quite often that I experience in the past is how do you create it from the district hospital to the regional hospital? We had a lot of problems that way because they get obviously a lot of referrals. But I mean, at one stage in Transkei working with Ben, I went to Bedford Hospital a couple of times, did ward rounds with them. And that kind of like built relationships and we could communicate better and help one another better. So whichever way it works in your area. And then the last thing I said was on the management ideas is create an outreach and support system. So visit the hospitals, know what they have and the skill set they have. And you've got to recheck on that every year because the new comm service doctors and, there's just usually a change around New Year. Go check what's their skill set and work on it. And every year do the same training if need be, but it's a big benefit in the year going forward.
Yeah, I think that's a good point about training. I mean, you just have to repeat it. Like that's the reality. We've got staff turnover in every unit countrywide. If you've got a standard of care that you're trying to maintain, it repeating it is important. I wanted to ask you, I think you mentioned something about M&Ms. Do you want to just as I talk about kind of maintaining standards, that jumps into my head, and then I'm going to ask you about ankle fractures, but maybe M&Ms first.
Cool. M&Ms in district hospitals, all of us need to do, all the departments do their own M&Ms every month at least. And if then you always said like by counting the numbers, we know what's going on and we monitor it better, and that's what all that the M&M is. So in your department, if your district hospital pull the orthopedic, the morbidity side of it into your M&M meetings, we tend to do a lot around obstetrics and the CHIP and the PIP and all those meetings. But orthopedics need to be revisited with the training. You need to look every year. And like this patient came back and that totally displaced fracture. We made a mistake. Track it down. What happened? But in our bigger hospital, regional hospitals, we need to do M&Ms in our departments and see how it's going and keep everyone in the team on the same page. Like even in Uppington, we need to talk within our department, orthopedics, so that we all do the same thing. So that is very important, and I think that's, you need to keep challenging the status quo as it is, and saying, like, you know, isn't it time for arthroplasties at Uppington? And we hope to be starting later this year. And then just, you know, say, okay, we need to get the basics right, the simple stuff, but like, how do we go forward? So those type of auditing stuff is important.
I think sometimes people feel that's, you know, a step too far because it's so busy, and, you know, the last thing we can do is actually think about analyzing our service. We're struggling enough to provide it. But, you know, I think the point that you make is that when you understand your service, then you can actually start to improve it. And you might find that there's things that you could do that could make significant differences. And you don't have to start with a fully fledged bells and whistles, you know, deep statistical analysis of, you know, whatever it is. You can just start with counting the numbers, you know, even that gives you some information. So there's so much that's possible. And obviously the other thing that we found was trying to find a champion, you know, somebody who's, and this could be an orthopedic qualified nurse, that would be wonderful. Or it could be anyone of the doctor team, who frankly, sometimes you'll find a physio or a OT or somebody who's got a passion about, you know, an orthopedic topic. And you could just be starting by counting the numbers and trying to understand what happens to those patients. Something as simple as that. The point of it is to just get you thinking about what it is that you do, and also to spread the message, I think, that there is a standard of care. And sometimes it's a little bit opaque, and sometimes the goalposts shift because of resources, etc. But hopefully it's you know, it's something measurable that you can look back on in time and see, hey, wow, we are getting better. Hopefully. Maybe can I bring kind of real life orthopedics, eh? I mean, it's Saturday night, the patient comes in, they possibly been drinking, given that it's Saturday night. But the point is, there's no x-rays, and you know, they've got a classically swollen, painful ankle, they're not standing on it. And what are you going to do? I mean, how do you approach that in a way that's good orthopedics, safe, medico-legal, practical, rural?
I mean, Ben, that's a broad statement. I mean, elevation and a back slab never hurt anybody. So, you know, that could be the start, and then do the x-rays as soon as it's available. I'm thinking actually about a case that still haunts me from Zitulele days, when we were at one stage, if I remember right, 3 months without x-rays. And a patient came in with what the doctor thought was a classic femur fracture or hip fracture. And like next day when we got the x-rays, it was a dislocated hip. And I realized afterwards, like, it's got two totally different presentations. And one, the leg falls outwards, and one, it's, you know, it's like, we never examined the patient clinically. We just, you know, knew something was broken and kind of left it there. And so for that kind of case, I love going back to the basics of clinical examination. Look at the patient, see, this is most likely dislocation. I'm not going to hurt them a lot if I just at least see if this thing reduces. And I mean, because it's two totally clinically, you know, presentations, and to go for it in that sense. With the ankles, the swelling, and you know, you just get it elevated until you get an x-ray to see if it needs to be reduced. I must say now, after the Eastern Cape, I've done a lot in you know, fixing the Weber bees that's badly displaced, you know, and just reducing them. You can do a lot with a clinical, you know, good analgesia, obviously conscious sedation, and then reducing them, you can do a lot. I just want to say something, you know, I said now management things, x-rays. If I just say the clinical things around there, I think there's 4 things we need to remember with orthopedics. I always suggest examine the patient well before you send them for x-rays, because usually a patient comes hobbling in, you say like x-rays, you know, and you do all your x-rays beforehand, and then you look at the x-rays and you send the people away or pop them. But if you examine, you think already, but it's not the ankle, this is higher, or it's not the elbow, it's the wrist, or things like that. So you so you look at the x-ray when it comes eventually with a different eye, and you don't tend to just hyper focus on where the patient said it's painful. I think we miss less that way. So that's my first suggestion. Always first examine and just get an idea clinically what you think is wrong, then send them for the x-rays. Do the joint below and joint above. I know we get the x-rays back. We've been waiting for half an hour, and then we see the elbow is not on the x-ray with a broken radio ulnar, and then we're just too lazy to send them back. I think we need to, on the one side, because we need to be sure. But on the other side, our x-ray department need to be kept on their toes. Our radiographers shouldn't be cutting corners like that. So get both joints, above and below. Do the post-reduction x-ray. I've often felt that we don't have enough money in government to do all these x-rays, but it costs very, very little these days. And I think with the medical legally, as this is, the stuff we're speaking about today, I think this is one thing we cover ourselves. And then the follow-up x-ray. In district hospital, I worked previously, I love just discharging, fixing and getting a circular pop on today and see them in 6 weeks and take it off. And saving the patient the transport somewhere in the middle. But if in any way possible, I would always actually follow the patient up in a week or two. Remove the back slab, do the circular pop, might be one reason, but also especially in children when the swelling goes down and that whole fracture displays on the radio ulnar, wherever, to recheck it. So I think we need to do that initial first early follow-up when we can still fix the problem with a close reduction, and then obviously at the end.
If I can jump in there, I mean, I think that we're past masters, most rural doctors, at making a plan, trying to make something efficient, and it's knowing where to cut the corner, where the plan can safely be made, or where the probability of the plan working out is good and where it's not. And I think that what you said is absolutely true. We do have to x-ray things. We've also got to think. So, is this a hip fracture or is it a hip dislocation? A clinical exam will often tell you. And I mean, if you're not sure, get somebody else to come and have a look with you and have a pull, unless you think you're going to do more harm than good. But I mean, leaving a dislocated hip out for 12 or 18 hours is doing harm. So, and the same with a shoulder. Obviously, it's great to have an x-ray, but if it's 12 o'clock at night and you don't have a radiographer, you just relocate the shoulder and then you get an x-ray the next morning. But I think that extra step of just do the right thing, get that post-MUA view or the post-pop view is super important, because that's definitely where I see the wheels starting to come off. And then just in terms of follow-up, I thought some safety nets are useful. I mean, we all know the risks of plaster in a swollen fracture or joint, etc. So you've got to be alert to that, because the problem is if you forget about that, or you just optimistically think, well, let's hope it's not okay, not a disaster. It is. The reality is people have their legs and their arms chopped off because we put on a plaster too tight, which is pretty disastrous, actually. So I think that there we have to safety net, because the reality of our patients is that sometimes they live far away. But I mean, ankles, I never put a circular pop on a swollen ankle, for at least 48 hours. And frankly, the MUA is often a waste of time as well until the swelling's coming down a bit. But when you're putting it on a swollen joint, you need to document that you've told the patient to come back if it's painful, sore, numb, etc. And you need to make a sensible plan that you can defend. So if the patient is over the road from the hospital, actually they should be having a 24-hour pop check. That is the standard of care, But if they 30 Ks away and they don't have money for transport, then making them come back at 24 hours or making them sleep on your bench just so that you can look at it in 24 hours is possibly not the most human thing to do. And I think that's where we have to use kind of our knowledge of the medico-legal risks, but also, and the right thing to do medically, but also our humanity. And that's, again, when it comes down to documentation. If you've got a fracture that's significantly swollen, you're going to have to bring that patient back at a week so that you can, review the plaster and see whether it's still holding the fracture acceptably. And if it's not, you need to replace it. The reality is simply that when we kind of just go blindly optimistically or say, well, they're too far away, therefore I couldn't practice good medicine. You need to actually engage the patient in that decision. Sometimes they can get back easily. They've got a sister who works down the road, or they come through to town every other week. They can get back. They've got private transport or money or something. So you've got to engage the patient in the decision. You've got to document the decision, and you've got to think about what's likely to happen with this plaster. And I think that the other thing that I think is a good habit is just look at the plaster. I shudder to think of the number of times I asked for a plaster to be put on, and then, the patient disappeared before I actually looked at it. And, depending on who's putting your plasters on, that may or may not be a significant risk. So making sure that your plaster technician is actually good and understands the risks and engages the patient. But it's your responsibility as the doctor to engage the patient. What about you can't do it, you can't get an RF today. Who's responsible for making sure that things work properly?
Yeah, I'm thinking, Ben, December in the Transkei, and everybody breaks their hips, and then we start phoning. We contacted our hospital. They said no beds. Phone me on Friday, and then you make a note. Today I'm going to phone on Friday, and then after a while it's like 4 or 5 weeks later. But I think I just remember the frustration, but the notes need to be very clear on that. And in the meantime, while they are there, you do the best you can. So, I mean, we developed some really interesting anti-rotation devices, so that, like, if the patient is 90 days in the bed, that the femur doesn't heal in, 90-degree angle. And things. So then we do the best we can, but to make notes that I discussed it with this doctor, and he said this very clearly. What the doctor, what you said about reasonable plans, like what they tended to do there is we would refer the patient on the day they say they went to the referral orthopedic hospital, and then they get discharged there with a follow-up date in 3 months' time and no RF done. And that's not, Ben, that's not legally defendable. So that's not a good plan. And if that patient would sue, they would have to explain themselves.
Yeah. I think, that's exactly right. I mean, wherever you're referring to some measure of responsibility, I think it's, incumbent upon us as the district hospital, as the primary care level, wherever you are, to take some responsibility for the patient. You might not be the person who's going to do the RF, or you might not be the specialist, but send the patient with their limb in as good a position as you can get it. That seems reasonable, both from a professional pride point of view, but definitely for the outcome. It might also make their job in the regional hospital a whole lot easier, because maybe you got it good enough. And the reality is that a lot of things that do get RFs in the private sector, or in the ideal world, as you said, we simply can't do. So if we get a good position, then we will often accept that. And then we need to, obviously, depending on how at risk you think that fracture is, make a more intensive follow-up plan, and make sure that you've documented things like non-weight bearing, and when the patient needs to come back, and what the plan is as well for your colleagues, because it might be that those follow-up visits are often found, if you made a good plan at the beginning, the follow-up visit can be super quick and efficient. If you didn't write good notes, then the doctor gets them next ends up having to go right back to the beginning again. So I think that there's things that you can do as a team in a district hospital as well that allow you to create efficiencies. And I think the same probably applies even at a regional hospital. I often got the sense that there's an unnecessary recycling of patients. Do what you need to do at the regional hospital, because you've got the specialists and the equipment, etc., and then send them to the district hospital for that 1 week visit and say, this is what I want you to check, assuming it's within their competency to do that. But again, as you said, the relationships will help you build that.
Yeah. Ben, can I say something around theatre?
Yes,
Because
thanks. I was going to say, do you want to touch on theatre and consent? I'm aware of time, and we want to give some time for questions. Theatre and
consent is first on my list, and your example of amputations. I mean, consent is all about giving them all the information so they can make an informed decision, and then also giving them reasonable alternatives. I remember when I worked in Ceres in the Western Cape, we had a lot of patients with peripheral vascular disease with a black foot arriving at the hospital. And then it's obviously, for me, it's all about amputation and pain management, but there's no rush. So, give the patient the details and say, like, you don't have to do it today. You can go home, chat to your family, get consent and come back and we do it, or not, as you decide. But there's no rush always necessarily. There's obviously exceptions where you need to reduce the elbow very quickly. Kids without their parents, obviously technical, but the consent is very important, even for the small things, the formalization of an amputation of a finger or something. Always get your consent nicely written down. That's the first thing. Second is the WHO surgical safety checklist. Have it available in your hospital. And I remember when I worked with Ben and Zitulele, we took the WHO one, but we actually rewrote it a little bit for Zitulele, because mainly we were doing Caesars, and there were some things that we didn't want to miss out on Caesar, so we added that on. But use it and get used to having that moment before you start cutting or doing the reduction or whatever. Just the moment that you stop and ask yourself, like, this is who I am, this is the sister, this is my assistant, this is the patient, this is what we're doing it for. It's one thing to do this in district hospitals. It always feels ridiculous where you saw the patient in casualty in the ward and now you're operating like, why am I doing this? But in district hospitals, in regional hospitals and even tertiary hospitals more so, the doctor that booked the patient is not the one that operates necessarily. So we have to be very sure, because avoiding wrong site surgery is a thing in orthopedics. I'm thinking it's the 8th most commonly sued condition in South Africa in orthopedics. I would have thought it was actually high on the list, but it's actually there. So it's something that happened. We operate the wrong side. So avoiding wrong
side surgery. And it can happen in district hospitals, the only reason it doesn't happen as much do such smaller amounts of surgery, but it's about doing the right thing. I had a patient once, I won't tell you the long story, but honestly, it was a long running argument over his definitely not going to heal foot after a lightning related burn, actually, or he fell in the fire, I actually can't remember. But anyway, we literally argued for weeks and weeks. I threw him out of the hospital at one point because it was pointless, and he came back and then he didn't want the surgery, etc. He eventually decided, no, he is now going to have an amputation. He was seen by another doctor in OPD, booked for surgery, and came, and his foot was already all wrapped up. And I thought, no, you know what? I'm the guy who's going to chop the leg off. I must actually look at the leg before I chop it off. Just, it's just do the right thing. And blow me down, his leg had healed to the point where I was not prepared to chop off his leg. And then he was like, you are mad. Like, you spent the last 3 months telling me I must chop my leg off, and now you refuse to chop it off. And I was like, no, I'm not going to chop it off. But it was a bit of a ridiculous scenario. But the truth of the matter was, I could have easily chopped his leg off, but because you're saving time, somebody else has booked him in, and you just have to take that moment to say, what is the right thing to do here? Just do it. It actually doesn't take a lot of extra time. Even taking consent, all of those kind of things, that's just how you got to do it. We used to say in Django CC1, and how would I treat this patient if they were my sister? Now, maybe you don't have time to make them a cup of tea and listen to a long sob story, but you can at least afford them the dignity of a properly taken consent and an examination, etc. And yeah, our patient numbers are overwhelming at times, but we've got to have some kind of quality of care. It's a super hard balance, and it varies from day to day, but I think that emphasis on trying to do the right thing and trying to be human. The other thing that I just want you to touch on before we jump to questions, I see there's one in the chat already. Patients sue when they feel the doctor's made a mistake and they're trying to hide it. I think you're very on it there. That's true. The doctor-patient relationship actually is a huge marker of who's going to sue.
Yeah, Ben, that's my last point in how do we protect ourselves is the communication. It's all the literature I looked at for this discussion, just saying the communication is vital. people sue doctors because they think they made a mistake. But I've seen doctors that made huge mistakes, operating the wrong hip. I mean, how much bigger can you get? But they went to the family immediately afterwards, said like, this happened. It's my mistake. I am sorry. But we're not going to let you down. We're going to fix it this way. We're going to do this. And then, and then afterwards being available. So patients feel like if they try to contact you when there was, infection was starting and, the side effects or problems started, and the doctor didn't want to speak to them, then they feel like they want to sue. And also like basically don't fail the patient. So if you have good communication and you are honest when you made a mistake with a patient, you're most likely not going to get sued, just because people understand them. We're all human and people make mistakes. Where if we block them and they feel that we didn't want to listen to them, then it's much more likely to happen.
It's so true. I trained as a mediator earlier this year, and they were talking about how, like, one of the critical things is to identify what they call the dignity violation. If you can see them where they're at, see them where they're hurting, and engage that as a human, it's not to say you're never going to get sued. You might still get sued, but your chance of being sued is going to be so much lower. I want to just touch on one or two questions. I mean, to people who are still listening to us, are we talking to ourselves? No, there's some people on the line still. That's good. Hans and I, we could talk, for a whole day on just this topic probably, and not get bored of each other's voices or our own voices. But hopefully some of this has been helpful. It's certainly not the last word on the subject, so please feel free to ask questions. I'm going to jump into this question from Squiggy Scotcher. Can I ask a question around ethical, moral responses to patients accessing care and government service, and then using their connections, often political, to fast track or jump the queue to access orthopedic surgical services ahead of patients who've been waiting their turn? Wow. Where do we start with that? I mean, my approach to the politicians of the day, I mean, to some extent we're beholden to them. At the end of we work for government, so if there's a interfering MEC or other senior party politician who's there and kind of forces your hand, sometimes you do have to give in to that to create the peace, or keep you might have a CEO who's losing their marbles because they think their job's on the line because some politicians there. I mean, the reality is that it's not actually acceptable, and we should be calling it for what it is. I always think about one traditional chief who I just respected so much. I mean, it took a few visits to hospital before I realized she was like the biggest chief in the area, because she always just came and sat in the queue, and I was like blown away when I discovered how senior she was in the hierarchy. And I thought that modeled what we want to see, and there are other people who try and push it, and we just got to say, I mean, just the same as we do to people from the private sector who sometimes come and think that they're special because they've got a medical aid or something. Everybody's special, but I'm not going to let you jump the queue. It can be difficult though, especially in government. I don't know if you've got any other insights on that, Hans.
I learned it from you, Ben. You got to play the politics. So sometimes it's not you're not going to actually operate the patient much earlier, but you're going to make sure that they are happy, and you're just going to like make them feel special. But in the end, you operate them the same day you would have. But it's worth putting the energy, because those relationships are so important. But in principle, we treat all our patients the same. Yeah.
No,
but
I think that's right. Use the opportunity to build a relationship with that political person, because the truth of the matter is they control the purse strings often, or they are. And so that means when you've got issues and when you don't have the hardware, or you can't get a post through, you phone them and ask them if they can help you. And it's not kind of you scratch my back, I'll scratch yours. It's make use of the context that you have. And I think when it comes to clinical decision making, it probably does mean that you're going to spend a little bit more time explaining things and smiling at them and whatever, even if you don't necessarily feel that way deep down inside. But you do have to play the game to some extent, unfortunately. You in the end get a bit further, I think. But I also think that it's important that people who don't have access to resources are not treated like second-rate citizens and get bumped down the queue. I just don't think that's acceptable. And I think when we give into that mindset, we're doing all of us a disservice as humans.
I'm thinking of the time I worked in Ceres, and we just didn't have enough beds, and people were always sleeping on the floor in casualty. And then we got the phone call from the MEC of Agriculture at the time, asking us why is his father lying on the floor with a stroke, post-stroke. And we said, like, is he complaining about the father or the other 10 that was on the floor, in a nice way. And that same Monday, that was a weekend, the Monday, we got a visit from the Minister of Health, Western Cape, and within a week, we had 10 more beds in the hospital. So, like, maybe look at it in a positive light. Suddenly, I've got the politicians are looking at our hospital, use it in a way.
Yeah,
so, yeah.
I think that's a great example. Yeah, politicians are about the people. I don't see any hands up. I'm just seeing if there's anything else that we'd kind of written down in notes that we wanted to touch on. I feel like after just reading these cases where patients have lost their limbs and things to too tight pops, just how that's just a really simple thing. And I mean, documenting it can be, pop dangers explained or whatever, but just actually making sure that we do give that basic advice that we sometimes feel like everybody knows, but obviously for our patients, it's their first time. I see another question there about supracondylar. Do you want to take it on?
Yes, can I answer that one? So supracondylars, when we worked in deep rural, there was no quick referral. So even for these severely displaced, the Gartland 3s and with rotation and everything, we tried, I was told, go for it, because if I just get it better position, which it's easy to get it better, not necessarily easy to get it perfect, but better, the swelling goes down, the pain goes down, and when the swelling goes down, vasculature is better. So I always went for close reduction and to just at least get the position better and the swelling go down with elevation and all those things. And then the flexion was up to where I get a pulse and then a little bit back, kind of like. And sometimes that means it wasn't 90° plus. Currently, where I work now in Uppington, our idea is more, if it's a Gartland 3, you send the patient, full stop, we'll do the reduction, because we do it within 24 hours if the patient is sent. And then we can even go to theatre and just pop in some KYs to get it in a perfect position. But the risk is if the artery runs right past, next to that fracture, and vascular injury, from what I understand, is quite a big risk. And if that happens out in Springbok, 400 kilometers away, the arm is going to be dead when they arrive here. So yeah, I would a Gartland 1 and 2, I will reduce, tell any district hospital to reduce, but probably the other ones, pop it in whatever straight position and send for a formal reduction at the referral hospital. That's ideal. If you don't have a referral hospital that do their work, you do the best you can, and that's probably trying the reduction where you are.
Yeah, I think that's fair. It is going to depend a lot on who you're referring to. I mean, I think the biggest things for me about a supracondylar that's displaced and rotated is you want to make sure that they're neurovascularly intact and that the bone's not tenting the skin. I mean, if you've achieved both of those things, I don't think you're going to run into trouble during the referral, to be honest. So, I mean, I don't know if we have enough details to make full comment on that, but those are the principles there. And again, documenting what you see.
I see Cody McGregor there asking the role of Dunlop traction for above question, if unsure about position. Cody, I actually saw a picture of Dunlop traction now recently, and I thought, like, why aren't we using this? Because you can fix any elbow with that, but I've never used it. So, and I think it's maybe a bit technical for district hospitals, but it's probably something to look at.
Yeah, again, I mean, I think where you are just determines such a lot. If you're down the road from your referral hospital, and you've got an ambulance that's working, that's great. If you've got a ambulance strike and you're 500 k's away, you might need to think about other possibilities. I think the question, that's super important as we come to a close. It's just it doesn't help almost in anything. No, let me phrase that differently. Knowing what we should be doing is super important. That's the first step. You can't get away without some knowledge. And then if you can't achieve that, the next thing is really thinking about, well, what's the next best thing? How can I be safe? And really, I think in everything that we've said, so much of it is doing the basics and documenting what we've done. It's such a I think we shy away sometimes from writing good notes, or we think it's like this long or it's going to be this long, but that's not true. You can write down simple stuff quickly. You can pay attention to simple things, easily. And the more you get into the habit or develop a system, what are the things you always do when you see a dislocated limb? What are the things you always do when you see an ankle fracture? Those things do take time to develop, but go through that system. Don't take shortcuts. And then those realities that we can't offer perfect care become secondary, because you're still doing the best you can with what you have, and you're documenting why you chose to do X, Y, Z, and you're involving the patient in your decision. I think that covers so much of that ground. If you leave out obvious things, like you don't give antibiotics, or you don't wash out an open fracture, then you're going to have issues down the line. So you've got to do the basics. And if you can't do it, then you've got to make a plan. I just feel like I'm trying to repeat myself, but that's it. It doesn't have to be scary. I think I remember the beginning of my commercial view. I was terrified of orthopedics and knew nothing at all. And it was by spending some time in the orthopedics unit and actually doing the stuff, realized, most of this is not scary. There's, you get x-rays, you can send x-rays and ask for opinions, and there's people who are able to help you. And I think even in district hospital settings, there's often somebody on your team who feels a bit more confident with bones. Give them a shout, ask them to teach you, ask them to show you how they did the MUA, etc., and get used to what's acceptable when it comes to angulation, etc. It's in the Rural Doctor Handbook. I just thought I'd quick shout out to the Rural Doctor's Handbook. Hans has a great chapter there called The Angle on Orthos. So make use of that as well. Steph, I think I see the time's 7:05, so we should probably call it quits there.
Okay, there is one question in the chat about how did you change the World Health Organization consent form to fit the district hospital? What did you add or remove?
Oof, I need to have a look at it. Do you remember, Hans?
I mean, in principle, you shouldn't do it. I guess that's probably what the powers that be say. But I mean, it was very rigidly written for big hospitals and checking. At Zitulele, we wanted to make sure that we've got the platelets, for instance, because we knew a lot of the seizures we were doing was for preeclampsia, for instance. So we added things like that. And what was that viral load? Before going in, we wanted to know, if the patient HIV positive, what's the viral load? It was just a reality where we worked that I want to know that before I start operating. And then in the post-op column or the post-procedure column, there was also some like, are we giving antibiotics? And then there was just a little tick for like weight, duration of operation, things like that, like what would like nudge you towards giving post-op antibiotics for 3 days or not. So it was small changes, but it was specifically for our hospital. But that's the only ones I can remember now.
Yeah, I mean, I would just make a general comment. I actually listened to a talk by Atul Gawande at an RCOG conference once, and he, these things are not set in stone. They're there as tools, and so I think if you get a version that's, because there's not only one version, sometimes they change and the powers that be haven't actually updated it. So what you're using is wrong anyway. But the point is, it's got to be relevant to your setting. And I think that's making sure that it's, sometimes it's just a layout, or because repeatedly asking a question that is meaningless in your setting means that people will get into the habit of not asking the question. And as a result, it's undermining the form. So for me, a form, paperwork, especially tools that we use, need to be fit for purpose. I am not, and that's why the bureaucrats love me so much, because mindless bureaucracy is for the birds. And there's no point in having a form that's just mindlessly bureaucratic, because people stop using it. So I would encourage you to, don't remove questions that are important, obviously, that will also undermine the form, but make it as practical and relevant to your setting as possible. That's what I would say. Yeah. I mean, even our consent forms can be improved a lot, but perhaps I won't get on that rabbit warren. Steph, is the poll up?
I'm going to do the poll now. I'm hoping it's going to launch. I hope. Can everybody see it?
Yeah, it's just popped up here. So obviously it was very useful, everyone. You can just we really honestly happy to have feedback on this what did we call it? On this format of conversation. We could have put all of this in a slide, but sometimes one gets tired of slides. So please.
Maybe people can just comment in the chat about the format.
In the chat. If you don't want Hans and me to see who said what, just send Steph a message to say, please tell those two guys to do PowerPoint next time. Got really tired of looking at them. Any last questions? Otherwise, that's probably it. Thank you, Robert. He said it was a nice change from slides. Hans is looking good for his however many years. I won't give your age away there. Really fun to chat to you, Hans. I'm glad they invited us. Thank you everyone for listening. I really hope it was useful. And you really are welcome to be in touch with me for any rural question really, but my current life is medico-legal. And you're welcome to phone Hans any time of day or night. He said he loves it when his phone rings. But no, seriously, actually, this is a very serious point. I think the truth of the matter is sometimes that, especially in rural hospitals, people feel like, I just wish there was someone to ask, and you don't know who to ask, and you feel like because you don't have a relationship, we haven't had a cup of coffee or whatever, you don't know who to phone. If Hans comes across as the kind of guy you can ask an orthopedic question to, phone him. Maybe not at 3 a.m. unless it's life-threatening, but phone him. He's very happy to give advice. I'm very happy to give advice. And both of us will tell you if we don't know. And there's actually a lot of other doctors out there who are similarly willing to give you some of their thoughts. So really encourage anyone who wants to reach out to do that. Dave Bishop always finishes his anesthetic slides as phone a friend. It's like, if you don't have any friends, phone me. How do you contact us? Hans, will you just type your number or email there? I'll just type mine. That's good.
Yes.
Yeah, give us a shout out, because
Good.
Great. Okay. Well, that's us. Thanks everyone for coming.
Thanks, Stephanie.
Okay, a pleasure. Sure, we'll rope you in for some more as the year goes on.
Love to.
Okay. Bye, everybody.
Bye-bye, everyone.
Cheers.